Hi guys, this is a lecture on vasculitis. We're going to cover GCA and a few important diseases here for the Plab 1 exam. GCA is super important. What does GCA stand for? Giant cell arteritis, also called temporal arteritis. So basically in the exam you need to know this is a patient who will be above the age of 50. Must be above the age of 50. Secondly, it's going to be a headache. Whereabouts is the headache? Temporal area, one-sided area. It won't be both sides, it's going to be one side. Thirdly, this patient is going to have jaw claudication when they're chewing the food. If they want to give you more easier symptom, the patient will have scalp tenderness. When they're combing their hair, one side feels tender. When you palpate the temporal artery, it might be tender, or you may have decreased temporal artery pulse. So these features are very, very important for the diagnosis. Plab 1 exam, they ask you they ask you to pick up the diagnosis of GCA. To help in the diagnosis, we need to know 25% of the patient of GCA have polymyalgia rheumatica. This is a condition that will cause proximal muscle weakness. So I will cover that on later on. Exam focus. They ask you, number one, diagnosis. Then they ask you investigation. The first thing you do when you suspect a patient with GCA, first thing you need to do is ESR, because they will have elevated ESR. Because in this condition, we need to quickly diagnose the condition. If we suspect it, we need to start treatment straight away. Why is that? It's because the vision loss. Because vision loss is very important. The vision loss occurs in GCA and it is irreversible. That's why we need to start the management straight away. The most initial investigation is going to be ESR, and the most definitive, the best test, the definitive test is temporal artery biopsy. Memorize this for the exam. Management. Whenever you see a patient you suspect GCA, first thing, ESR. If ESR is high, you start the management. Management depends on two things. Does the patient have visual symptoms, or does the patient have no visual loss? If the patient in the exam is coming to you, patient has symptoms of GCA and they have visual loss, you can't wait. You need to start aggressive management. So you need to start them on IV steroid and immediate referral to ophthalmologist, IV steroid, because you can't wait. Because if they have one vision loss, then you need to start them on IV steroid to prevent the vision loss of the other eye. If they don't have vision loss, you still need to work fast. You need to give them high dose oral steroid because you want to prevent vision loss. Okay, exam focus is that this patient will be on steroids for long term. If they have GCA, it's for 2 to 3 years, and they need to be on PPI. Okay, because steroid will cause peptic ulcer. Steroid will cause osteoporosis. They should be on bisphosphonate because of osteoporosis. First thing you do, investigation, ESR. After that, very soon you need to arrange a biopsy, temporal artery biopsy, because this is the most definitive test, and you need to make sure that you have the diagnosis, because the patient will be on long-term steroid and it has its consequences with it. Exam focus, as mentioned to you, visual loss, what to do. I mentioned to you about the steroid and the management. Polymyalgia rheumatica, super duper important. 25% of patients with GCA have polymyalgia rheumatica. What is this? This is an chronic inflammatory condition. In this condition, this patient will have high ESR. So what is this condition? So it is linked with GCA. Patient with GCA have this. This causes proximal muscle weaknesses, meaning it's affecting the proximal muscle. So the patient can't get out from the chair, because to get out of the chair, you have to use your proximal muscle. They can't get out of the toilet seat. They can't climb the stairs because it's using the proximal muscle. This is the key thing, proximal muscle weaknesses. Second thing you need to know, you will have elevated ESR. You must have elevated ESR. The symptom gets worse in the morning. Okay, elevated ESR. Management is going to be steroid. Second thing is that this condition, polymyalgia rheumatica, and this one here, polymyositis and dermatomyositis, very, very important. This one here is associated with GCA and this one is not. Both of them, polymyositis and polymyalgia rheumatica, both of them involve your proximal muscle weaknesses. But what are the differences is here. In here you have high ESR, and in the other one you don't have high ESR. This is polymyositis. So let's look at the name. Myositis, inflammation of the muscle fibers. Polymyositis. Other one is dermatomyositis. How do you differentiate them? Both of them involve the muscles. but one of them involves dermato. Dermato means skin. It has skin manifestation. So let's look at the common one, myositis, inflammation of the muscle. So both of them causes symmetrical proximal muscle weakness. So they both get the same signs and symptoms of polymyalgia rheumatica. So you need to, in the exam, differentiate between them two from the investigation. Investigation is going to be CK. Elevated CK. CK is a muscle enzyme that will be high in this condition. In polymyalgia rheumatica, CK will be normal. In terms of both condition, will cause proximal muscle weakness, I said to you, and severe cases it causes dysphagia and respiratory failure because this is involving the muscle. In terms of dermatomyositis, the difference between these two is the involvement of the skin. Dermatomyositis involves the skin. It causes two things you need to know. First one, heliotrope rash. This is basically reddish purplish rash around the eyelid here, and the other one you need to know is that a shovel sign, a macular rash over the back and the shoulder, like here. These two you need to know. You need to know the investigation is elevated CK because this is myositis, and you need to differentiate from polymyalgia rheumatica. The most definitive investigation will be muscle biopsy, which will show the muscle necrosis. Okay, management in here, physical rest is important in active disease because it's the inflammation of the muscle, so give them a rest, so that will decrease the CK. Oral steroid is the management. Exam focus, you need to know the differentiation between polymyalgia rheumatica and myositis and polymyositis. CK is very, very important because I mentioned a general point here. CK, you will have a high in rhabdomyolysis, you will have a high in polymyositis, and also in rhabdomyolysis the management will be is IV fluid, which we'll do later on, and other few things that is important in Plab in association with CK. This is just a general point. We'll do it later on, but I'll put it here because it's super duper important and it's